Well, I must say that I was tickled pink about 6 months ago when I see an email from former President Lorna Marsden. I thought, wow, this is a special day. I've had the pleasure of working with Lorna on a couple of committees, in fact, hiring the new dean for the Faculty of Science. And to work with Lorna was actually one of the most interesting and special things that I've done as far as my service to the university. So thanks for the invite, Lorna. I do appreciate it. And thanks for coming today. All right, I think we all know that diabetes is really one of Canada's most pressing health problems. That's maybe why we're here today, to learn a bit more about it. The Canadian Diabetes Association reports that about 9 million Canadians live with either pre-diabetes or diabetes. On average, we're getting 20 new cases an hour in this country. But what's even more disturbing is that each decade, the prevalence is nearly doubling in Canada. Now, these are large numbers. In fact, they're sort of hard to comprehend. So if we think of every person in Canada who has a problem with blood sugar is a penny, and if we stack these pennies on top of themselves, a penny's about 1 millimeter. How many CN towers do you think we have of persons living with blood sugar problems? 1, 2, it's 10. 10 CN towers worth of diabetes. Now, Dr. Zinman, who's a very well-known clinician downtown, has this quote: "The tsunami of diabetes has devastating impact, not only on the patients affected, but their families and the healthcare system." So let's think a little bit about the economics of the condition itself. This is an expensive disease. There is the economics of hospitalization costs. Hospitalization at the time of diagnosis of your young child diagnosed with type 1 diabetes. Hospitalization later in life if you've had limb amputation because of your diabetes, or blindness, or required kidney dialysis. There's physician costs, and that's generally a complex combination of primary care physicians as well as specialty care physicians in centers like the Toronto General or Mount Sinai Hospital. There's medication costs. There's costs of insulin and different pharmacological agents for type 2 diabetes, but there's also medications associated with the high cardiovascular risk for this patient population. There's loss of economic output and certainly long-term disability. And if you look at the cost of diabetes in Canada in 2000, it was around $6 billion of direct and indirect costs. And by 2020, the cost will be over $16 billion. Our healthcare system cannot afford this. So I've already shocked you, I think, with this tsunami of diabetes. The objectives for the next 40 minutes or so is to talk about the pathophysiology of the disease. If we understand why we get diabetes, then maybe we've got a shot at trying to cure this epidemic. We'll talk about some current prevention and treatment strategies for both type 1 and type 2 diabetes, determine if they're working or not. And then we'll contrast the benefits of risks of exercise, which I will stand here today and say is the cure for type 2 diabetes, versus a pill. So what are the various types of diabetes? Well, there are several types. These are the 3 most common. Type 1 diabetes is the type of diabetes associated traditionally with childhood. And many of you know that insulin, the hormone that saves this patient, was discovered in Toronto in around 1920 by Banting and Best, Collip and MacLeod. And this is a photograph of Elizabeth Hughes, who was a daughter of a senator from the US, who was one of the first patients to receive this life-saving hormone, insulin. And you look at her. She was being kept alive by a small porridge of gruel that she'd eat every day, maybe 600 calories. Physical activity and water. That's what kept her alive. On average, without insulin, you can live maybe 6 months. Lucky for her, she was born the same, or she was diagnosed and treated the same year that insulin was discovered in Toronto. This is a remarkable picture of her 6 months later after her first insulin injection. This injection she'd have to take every day for the rest of her life. But Elizabeth lived to a ripe age of 70 with this condition. And she looks pretty normal, but she's not quite normal. We still have a problem in the management of this patient with type 1 diabetes. As they grow older, they develop complications from the disease. And they have lots of high blood sugars and low blood sugars, even though we have this hormone that we can now deliver. What about type 2 diabetes and prediabetes? This is really what's driving the epidemic in Canada. Although type 1 rates are rising gradually, and we're not sure why, it's the type 2 diabetes rates that are growing exponentially. And it appears to be linked to obesity. And in some high-risk populations, it's not just obesity, but where that extra weight is kept around the midsection. So type 2 diabetes, formerly called adult-onset diabetes, is the one that we need to try to solve as the epidemic grows. Now, finally, gestational diabetes. Gestational diabetes is a temporary form of high blood sugar that the mother gets when she's pregnant. And that's why we go in, if we're a mother who's recently become pregnant, and we do that glucose tolerance test. This runs in families, and it's a temporary form of diabetes that typically disappears after the baby's born, but then reappears in the form of type 2 diabetes about 10 years later. These mothers typically have very large babies, over 9 pounds, sometimes 12 pounds. And these babies are at risk of developing type 2 diabetes later in life. Now, the symptoms of all these different forms of diabetes are, at first, symptom-free. You could be sitting in the room right now, you could have high blood sugar, and you wouldn't know it. With time, though, in all of these forms of diabetes, we typically have this list of symptoms. There can be weight loss, and you saw Elizabeth's picture, how thin she was with her diabetes. If they have type 2 diabetes, you may think you're doing actually pretty well health-wise because you've dropped 10 pounds. There's excessive urination. You're getting up to pee in the middle of the night 3 times. After a meal, you can't even finish a meal without having to go to the washroom. And that's because your body's trying to clear the glucose. There's blurred vision, which is temporary. After treated, your vision comes back and is normal for at least a number of years. There's high risk for infections, extreme fatigue, thirst, itchy skin, hunger, and sometimes you will be diagnosed with heart disease first, and then they'll look at your blood sugar and realize you have diabetes. So cardiovascular disease could be a symptom of your diabetes. Now, this disease has devastating complications. Many of the people diagnosed with diabetes die from heart disease. It increases our risk from dying from heart disease by 2.5-fold. It's the leading cause of blindness in Canada. It's the leading cause of kidney failure and dialysis in Canada. It's the leading cause of amputation and also contributes to other nerve and small vessel conditions like erectile dysfunction and impotency, as well as vascular problems. Now, we measure blood sugar control based on a blood test called a hemoglobin A1C test. And if you're diagnosed with this disease, we need to know how you're managing with this condition. This blood test measures the sugar coating on a molecule within your circulation, the red blood cell. If you have a lot of sugar in your bloodstream, you have basically a Cocoa Puff. And if you have very little blood sugar, your blood sugar or your molecules are more like a Cheerio. So the more they're sugar-coated, we can test how good your diabetes control is. And we focus a lot on this number, a hemoglobin A1C, because we know from landmark studies, like the Diabetes Care and Complications trial, that if you have a normal blood sugar level with diabetes, or only slightly elevated, your risk for developing complications is low. It's normal. However, it's very challenging to maintain this level of glucose control throughout your whole life. Many of our patients are above 7, and many of the kids who I meet at the sports camp have blood sugar levels already averaging 10 on the A1C scale. So there's a 12, 13-year-old girl with diabetes who comes to our care, and she's at risk for a heart attack at the age of 30. She's at risk for blindness at the age of 30. This is the number we focus on. the hemoglobin A1C. But it's not the only thing we'll focus on. And today we'll talk about the relevance of exercise independent of A1C. Now, type 1 diabetes was formerly called juvenile diabetes because it was the type of diabetes associated with being a child. But that's a little bit inaccurate because you can develop type 1 diabetes at any age. This is a bizarre autoimmune disease that requires both genes and environment to trigger it. Now, my son has the genes for this disease, and he may never develop it. If we knew what the trigger was, we'd probably help prevent this condition. Could it be hypercleanliness? Could it be hyperdirtiness? Could it be cow's milk? Could it be a virus? These are all theories, and no one knows what the trigger is. The defect in this autoimmune disease are the beta cells within the pancreas. And our pancreas lies below our stomach and does a number of things for us, including helping us digest our foods. But the only cell that's damaged in this disease, type 1, are the beta cells, the insulin-producing cells. And once they're damaged, there's no bringing them back. So this is a permanent condition, only treated with insulin. That's why it used to also be called insulin-dependent diabetes. Remember, insulin was discovered in Toronto, but it's not a cure for this condition. This is a photograph of Teddy Ryder, who's that same boy I just showed you. Teddy Ryder lived to the age of 70. He was one of the first patients with Elizabeth to receive this life-saving drug. And if you know anybody who has type 1 diabetes, the book by Michael Bliss is a fantastic read because it talks about the discovery of insulin and what it's like to do research in a biomedical laboratory. And it's a great read. Another interesting read, though, is this more recent text by Chris Faulkner. Chris talks a lot about how we thought we had a cure for this childhood disease, but realized that this was a bittersweet discovery because that poor child had to live with daily insulin injections. You can see this young girl poking her insulin into her thigh. Blood sugar management by poking her fingers, and realizing that she's at risk for early mortality in her 30s or 40s. And that's why, for me, working with this patient population here on campus is so critical, because this is not a cure. This is just a treatment, insulin. Now, Jocelyn was a physician who was at Harvard practicing diabetologia, or diabetes medicine, in the late 1800s and early 1900s. And he had this quote, which I think is a motto for me. We need to diagnose diabetes early, treat the condition vigorously, including the use of carbohydrate-restricted diets and fasting, and getting regular exercise. Now, we now know that diabetes doesn't have to mean a low-carbohydrate diet. We can have a child go to a birthday party and have her cake because she has insulin. But still, nutrition and exercise are still critically important for keeping these individuals healthier and living longer. And Jocelyn himself would give medals to patients of his that lived with diabetes complication-free for 50 years. This is the Victory Medal. Now, this medal is something that he drew himself. And if you look very closely, you see a young child sitting on what's called a spiked team of horses, trying to manage a wild set of horses, all running in different directions. The insulin injections, the diet, and exercise. These are the tricky components to pull together to make that child live longer and healthier. And that's what we try to do with these individuals. Because if you can get these three horses pulling together, you will have success with this condition. Dr. Marsden asked me to mention a bit about the sports camp. And this was an idea that I had about 5 years ago after attending an adult specialty camp in the US that I helped to develop. I thought, why don't we have a kids-specific sports camp where kids who are newly diagnosed or have been living with this condition for 3 or 4 years can come together and work with mentors and diabetes coaches, often college students from York who have type 1 diabetes, working with varsity athletes and varsity coaching to get the care of diabetes out of the clinic where that child sits there and the physician circles all the bad numbers that that child has. Why not get them in an environment where we can learn from each other and motivate each other? Running this camp now for 5 years changed how I take care of my diabetes. I have a little video. Hopefully the sound works on this.
York University is hosting a 2-week camp in partnership with the Diabetes Hope Foundation to encourage children with type 1 diabetes to live active lives safely. The camp was founded by York University professor Dr. Michael Riddell.
This camp is in its 4th year, and it is a sport-specific camp designed for kids with type 1 diabetes. The kids come in and they choose a sport of interest like basketball, soccer, tennis, track and field, and they work with both varsity athletes and counselors with type 1 diabetes to try to improve some strategies around sport and blood sugar control.
Okay, so part of our role is we help the campers do carb counting at lunch. So we help figure out how many carbs are in the meals that they're eating, and we help them figure out if they need help, what insulin dose should go along with that amount of carbohydrate. So that's part of what we do. Another big part of our role is we put continuous glucose monitoring sensors in some of the campers. So this is what a sensor where the needle has already been removed. Basically, this flexible little piece here goes underneath the skin and stays there. Then we put a transmitter onto it, like that. So this is what you see on the outside of the body. This is what's doing the work, checking the blood sugar, and then it's reflecting on the screen here.
Blood sugar control might get a little bit worse with exercise. You see lots of lows and lots of highs. So in the environment of this camp, what we try to do is flatten out some of those blood sugar levels to try to keep them at a more stable level.
While the campers are learning how to manage their diabetes, they are still having fun.
Some of the kids have diabetes and that they have to be careful of how much they exercise. But other than that, there's nothing much different with the camp. They're kids, they're having fun.
It was really fun. I got to relate myself to the other campers that had diabetes, and we got to share each other's opinions, got to help each other out.
Here they give you advice, and they have sugar tablets to give you if you go low, so it's a lot easier and probably safer.
Well, I guess the idea really came from my own diagnosis of type 1 diabetes at the age of 14. I was a pretty active adolescent, liked to play basketball, and there really wasn't much that I could find to help athletes with diabetes.
Through the support of the Diabetes Hope Foundation, campers have access to counselors trained to work with youth with diabetes and daily transportation to and from the camp. In addition, the foundation is sponsoring youth from low-income families to attend. Dr. Riddell hopes that the support and education at the summer camp will give the campers the skills they need to live a healthy lifestyle.
That took a couple takes, but he did get the layout. So you see we're working with industry leaders and partners on the state-of-the-art technology to help these kids live a better life. And this technology has evolved in the last little while. It used to be that you would get this vial of insulin that was all cloudy and had all sorts of contaminants in it, and it wouldn't be very effective. You'd take a dose of insulin, and its effects would be about 4 hours after you inject it. So it was tough to time these out with meals. But now with new technologies, new sensors, we are helping these kids a lot better. And this little device at the bottom is the one that I was one of the first to work with in Canada. And this is a device that's an insulin pump along with a glucose sensor that's implanted into a child. And that sensor can communicate with the pump and deliver the right amount of insulin, which is amazing technology. This is called closing the loop, meaning that at some point soon, this will be basically an external pancreas that child will have and have hopefully normal blood sugar control. This is typically what blood sugar control even looks like with that type of technology, though it's still not perfect. If your blood sugar was perfect, like many of you in the room right now, it would be flat at 5 millimole and not change if you ate, not change if you exercise. And here we have a tracing of a child who is under very good control on almost normal hemoglobin A1C, but you can see still lots of highs and lows, which are very uncomfortable for that child. And in fact, life-threatening. These lows that we can capture if the blood sugar drops below a critical level can actually contribute to a condition called dead in bed syndrome, where the mother walks in the morning and the child has died from severe hypoglycemia. So this is a condition that we're hopefully trying to improve and manage. Now, we'll move on to type 2 diabetes next. And the natural history of type 2 diabetes is very different from type 1. Type 1 is an autoimmune disease, happens fairly rapidly. And type 2 diabetes is a very slow, incessant process that takes maybe decades to develop. Type 2 diabetes is really a problem with two different physiological functions. One is the body's sensitivity to their own insulin, and the other is the capacity to secrete enough insulin given the body's sensitivity. So we often try to illustrate that in a line graph by showing that when you go from being normal to pre-diabetic, then your insulin resistance gets worse and worse, and to compensate, your body produces more and more insulin. This is an adaptation that occurs naturally, and in some people occurs very, very well. They can be several hundred pounds overweight and never develop diabetes because the body produces enough insulin. But in about half of us, the body actually decompensates insulin production. Insulin production goes down, and then blood sugar finally goes up, and then the patient will develop symptoms of high blood sugar. So my feeling is that what we're doing in Canada is unfortunate in that we're typically diagnosing and treating type 2 diabetes at the very end, at the very late stage, when insulin production in the pancreas is kind of already dead, and it's very hard to rescue it at that point. So my idea is to diagnose more people in the pre-diabetes range and then provide lifestyle interventions to maintain beta cell mass, maintain insulin function, and to improve insulin resistance. Type 2 diabetes and pre-diabetes it's a lifestyle condition. It's not entirely lifestyle. There are many of you in the room who have a very normal body mass, and maybe because of your genetics will develop type 2 diabetes anyway. But the epidemic of diabetes in Canada is because of lifestyle and because of immigration from high-risk countries like South Asia, Asia, and the African Caribbean countries. They're so predisposed to developing diabetes, even if their weight is good, which is unfortunate. You can see that the incidence rates for male and female are comparable. Males are at slightly higher risk than females because they tend to be more obese than females, and they tend to carry their extra weight around the midsection, which is contributing to the insulin resistance and the breakdown of the pancreas. What's really unfortunate right now, though, is that the name type 2 diabetes had to be, the name adult diabetes had to be changed to type 2 diabetes because more and more children were developing this form of diabetes. So being overweight and inactive as an adolescent and developing type 2 diabetes when you're 15 or 16, which is very unfortunate. That predicts early mortality, obviously. So the name has been changed to type 2 diabetes just for that reason alone. Now at York, we developed a strategy for trying to assess prediabetes in some of the high-risk communities. And we did this in partnership with the Public Health Agency of Canada and some other collaborators, including the Trillium Foundation. And you might even look at this list yourself and try to figure out your own risk. If you check off any one of these boxes, you're at moderate risk. And if you check off half of these boxes, you're at high risk. And if you've checked them all off, you probably already have diabetes. Are you over the age of 40? Most of us are. Do you have a parent, brother, or sister with diabetes? Are you from one of these high-risk communities or ethnicities? Do you have a mother who gave birth to a baby over 9 pounds? Maybe that baby was you. If you were born over 9 pounds, your risk is up. If you've ever been told by a physician or a nurse that your blood sugar is elevated on a point-of-care blood sugar test, you're at risk, and so on. So we identify high-risk individuals using this very simple pen and paper test, and then we can confirm it with our point-of-care blood test, and then we recommend an exercise program for you in a community center. What we're noticing is that all of these risk factors tend to point to excess fat within the viscera. And here is a CT scan of two different men of the same body weight and the same total amount of fat. So the man on the top, his total fat in his body is around 19.8 kilograms, and his friend has exactly the same amount of total fat, but the fat in the cross-section, right where the belly button is, of this one man on the top, has so much concentrated fat that he differs very differently. He differs from this man who carries a lot of his fat in the subcutaneous depot, so you can pinch that fat. It's the fat you can't pinch that you should be worried about, because it's the fat that's contributing to this disease. It's contributing to insulin resistance and to the beta cells to fail. So this evolution of diabetes, this epidemic, is really associated with lifestyle. Our bodies were designed to be hunters and gatherers. And in fact, if you look at the First Nations people of Canada, they survived based on being able to store fat and live for a long period of time without a lot of food. And now we subject them to too much food and less of a hunter-gatherer society. This is really the problem. So we've engineered activity out of our lives. And so one of the root causes of this disease is physical activity, and only the restoration of physical activity and not medication will restore or normalize this epidemic. Many of us think about medications as being a quick fix. And boy, there's a lot of money, more money being spent on medications for diabetes than for any other disease in the world. More money being spent on this one discovery that will never happen than you can imagine. We could build 100 faculties of engineering buildings, maybe even a health building. But why do we look for this cure in a pill form? Why isn't it we don't do it the old-fashioned way, through lifestyle? Is it because nothing else is working? Is it because the pill actually corrects a deficiency in our body that exercise can't? Is it more effective than being physically active and eating right? Is it safer or easier than exercising? None of these are true. Why do we keep looking? What we typically do if we're looking for a drug is we look at a metabolic pathway in a cell. And this is a map of a metabolic pathway. And this doesn't even show all the pathways that our cells have with respect to metabolism. And then some scientist, usually in biology, will say this one pathway is deficient, and we'll give a drug to target that one pathway. It's a pathway, let's say, that helps us store our fat in a different part of our body. And then they'll do this study in a rodent, and then there'll be a press release that says something like this: 1 pill a day could cure type 2 diabetes. And these studies never materialize to humans. Never. You know why? Because they cause cancer, because they cause heart failure, because they don't work, because the metabolism of a mouse is different than the metabolism of a human. They never work in humans to prevent this disease. So if you're thinking about the exercise pill, forget about it. These are the list of pills that have been FDA approved for the treatment of type 2 diabetes. Do you think if any of them worked, there'd be such a long list? No. People are still looking. There's still patents being filed. We're still trying to discover the magic bullet. And many of these make it onto the market for 5 or 10 years, and then they have to be pulled because patients are dying on these medications. There are some medications that are very effective if you have type 2 diabetes. And I don't mean to stand here and say that you should go off your medications if you have this disease. But don't use these medications to prevent the disease, is what I'm trying to say. Look, for example, at metformin. Metformin is the safest, most effective drug for the treatment of type 2 diabetes. It's the one your physician puts you on like that if you're diagnosed with type 2 diabetes. It's an excellent pill for type 2 diabetes. Does it prevent diabetes? No. In fact, it lowers the risk of developing type 2 diabetes by about only 15% if you consume this pill twice a day for the rest of your life. It's not effective. So the problem really is insulin and insulin signaling. We need to come up with a way of producing more insulin and to have it work more effectively. And no medications are doing that. If you're resistant to insulin, it's not able to do its job, and you need more of it. And perhaps a certain genetic can be to blame for this, but it's really an interaction between your genes and the environment. What we've noted in our lab and in other labs is that stress itself seems to affect your insulin sensitivity and your body's capacity to secrete insulin. And we know that there's a lot of stress in our lives, and we often don't combat our stress with physical activity. It's stress that we're having in the workplace. We have this stress response, and it's no longer a fight or flight response. It's just sitting there and getting yelled at, perhaps by your boss or maybe your spouse, wherever the stress is coming from. Financial stress, who knows? So here's the problem. It's insulin resistance. We have to target that first. It's coming from the obesity epidemic. It's because of excess fat storage in our livers, in our pancreas, and in our midsection. and it's because of sedentarism. I like this cartoon, or this image. It says, sedentary people can't run away from disease, exercise. This is from the Portuguese Health Society. So I want you to leave with the idea that exercise and physical inactivity is the root cause of not just diabetes, but other diseases that are associated with diabetes. The root cause of cardiovascular disease, musculoskeletal disorders, many psychological disorders, cancer, and pulmonary diseases are because of an inactive lifestyle. Not always, but at least 50% of the time. And medications, while they're very good at treating the symptom of disease, they don't really attack the root cause of the disease, and that's physical inactivity. So we can treat high blood pressure. We can treat a bad lipid profile with a pill, but that's not getting to the root cause of the problem, which is inactivity. So if we're more physically active, we naturally see improvements in insulin sensitivity, a better body fat distribution, and a better body weight. We have a better blood lipid profile. It improves beta cell function, reduces inflammation, and so on. So the problem, though, and we get criticized for this a lot, is that it's not just a simple energy balance equation. It's not just energy in, energy out. It's not just physics. Some people are more prone to storing their fat in certain regions, and some people, no matter how hard they diet and exercise, they still have blood sugar problems. So it's not a simple equation. In fact, if you put it in the context, and being at York has taught me a lot about this, is that there are other external factors that can impact this equation. And these are social factors, these are environmental factors, these are biological factors. And I learn a lot of this from our colleagues here at York. I realize that the social environment predisposes us to choosing more foods that are unhealthy. So there's more advertising for foods. We're inundated with fast foods. And because our lives are so busy, we're gravitating to those foods that give us some sort of satisfaction. We also know that our physical environment is not engineered properly. How many of you take the stairs when you're in a building? You'd rather take the elevator. How many of you drive to the corner store rather than to walk? We are engineering this out of our society, which is the problem. So it's not an easy fix by no means. We've got issues of behavior, and then we've got the biology, which is impacting the foods we gravitate to and how we distribute our food within our bodies. It's not a simple solution. But we have to try, because to treat this condition only is just the tip of the iceberg with medication. We need to focus on prevention, because once this glacier flips, we'll be broke in this country. So prevention, if you look for the prescription, it's actually pretty straightforward. How much exercise, when to do it. It's all right here. We need to eat a healthy diet that's low in simple sugars. We need to eat a healthy diet that's low in saturated fats, and we need to exercise about 150 minutes per week. These can be brief 10-minute walks done 3 times a day. That's 30 minutes of extra physical activity. Done 5 days a week, there's 150 minutes. And remember metformin, the best pill on the market for diabetes treatment, reduces diabetes risk by 20%. This prescription lowers diabetes risk by 60%. No pill will ever do that. Now, these pills are not complication-free. In fact, many of these diabetes pills cause weight gain themselves. They could cause low blood sugar. They can make your cholesterol levels worse. They can cause nausea, vomiting, gas, bloating, diarrhea, maybe one positive side effect, loss of appetite. Some of the more severe side effects of these medications include muscle weakness, bone fractures, trouble breathing, heart dysrhythmias, muscle pain, kidney and liver toxicity, and heart failure and death. I'm not telling you shouldn't be on these medications, but why not be on the lower dose if you're physically active? Or maybe try to achieve going off the medications altogether. So pharmacological agents and regular exercise, they differ really. And the lack of the drug was not the initial cause of sickness, whereas the lack of exercise is a major contributing factor to this disease and other diseases like it. So new drugs may use some of the molecular mechanisms that bypass the cause of disease in an attempt to restore normal physiology, but exercise itself can prevent the disease altogether because it's the root cause in the first place. Now, the biology behind why exercise is so effective at the cellular and molecular level is fascinating to me. And we got an article published in the Physician in Sports Medicine to illustrate the biological actions of exercise on diabetes development. And we've been studying these pathways and mechanisms for a number of years, and there's a number of labs who do this work. What's amazing about exercise is it doesn't just affect your muscles or your heart. It's affecting your fat cells. It's affecting your pancreas. It's affecting your liver. It's affecting your brain. And we've mapped these changes out at the cellular and physiological level. That's why no one pill will ever do what exercise does. And we now know that exercise can come in two basic forms. It can become in the form of aerobic exercise or in resistance training with weights. And they both independently will improve our metabolism through multiple pathways to help prevent or to improve this disease. You can find this whole paper on my website if you'd like to read it. I'm also very proud of this publication from March issue of Diabetologia, the most prestigious journal in Europe for the study of diabetes. And this was a collaboration with another professor at York, Dr. Jennifer Cook. Look at this man. Type 2 diabetes, exercising and drinking water. What we found that was actually quite revolutionary is that exercise works independent of blood sugar control to save lives. And physicians often will look specifically at that hemoglobin A1C number and say, you're a good diabetic, you're a bad diabetic, we need to give you more pills to make you better, by looking at that number. And you're not a number, you're a human. And what we showed with thousands of patients is that even if your blood sugar control is not that good, it's over 7, if you're physically active just 30 minutes a day, your risk from dying is no different than someone who does not have diabetes. And at all levels of blood sugar control, if you just do exercise, you lower your risk from dying by 1/3, predominantly because of cardiovascular disease risk. You won't die of that heart attack prematurely if you're doing that exercise. So the aerobic exercise that we need to prescribe are activities of large muscle mass. Things like pole walking is fantastic because it uses a lot of different muscles in the legs and in the arms, and it's using oxygen. Things like swimming, if it's warm enough in Ontario, she's got a toque on, but the weather is getting better. The weather is getting better for aerobic exercise, and we should enjoy that 10 to 30 minute walk. What we found fantastic in our lab in the last little while is that even if you're genetically programmed to develop diabetes, this type of aerobic exercise, swimming for example, saves the pancreas from dying. And we did this in a rat model. So this is a Zucker diabetic fatty rat, and this rat always gets diabetes at the age of 10 weeks, which is like middle age. 100% of the time, always does, unless it exercises. And we were the first to show that the exercise benefits were not just in the muscle, but actually in the pancreas itself. This is a section of the pancreas. These are the cells that produce insulin. At 6 weeks and at 20 weeks, these cells are dead if they're sedentary. And we still have them alive if they're swimming just 20 minutes a day. These rats actually like to swim. They're very good at it. And what we found is that these rats that are swimming daily have new beta cells. This is a revolutionary discovery because what it means is that if you exercise every day, you can make new insulin-secreting beta cells and save the ones that you already have. Resistance exercise, another big study we've done in humans, shows that this exercise is very beneficial and very safe. And we've taken individuals up to the age of 80 years old with type 2 diabetes and shown that this type of exercise twice a week can improve their blood sugar levels. Some recommend 3, but we've seen studies twice a week are just as beneficial. Things like chest press, shoulder press, arm raises, etc. Do you have to have a gym for this? You don't have to. But it's certainly fun sometimes to go to a gym with friends if you can afford it and have a trainer if you can afford it. But you don't have to. You can do them at home. I'll end off with this new approach we have, and this is the prepaid study, which I coined because of the idea that I had to prevent diabetes, target pre-diabetes. And this is an investment, really, in the future. So pre-diabetes prevention and physical activity intervention delivery program. Why this is such a fantastic idea is because we have students at York coming from high-risk communities. They are multicultural, and they're going back with their university degree educations, working with the high-risk population. So there's buy-in from that community. And we're using York students, which is fantastic. It's community-based, so the exercises are done at accessible community locations. It's subsidized by grants for now. It's using social networking to foster adherence and continued activity beyond the research project that we have. We're targeting prevention of diabetes with exercise. And it's culturally preferred activities. So we're making them do or asking them to do activities that they like to do, not just making them sit there and do sit-ups every day. So the goals really are to provide a framework for sustainable community-based programs of an exercise prescription that we know from evidence-based research prevents diabetes. And this is a massive connection that we've developed with York as the hub. We've got community partners with the Ministry of Health Promotion, Ontario Trillium Foundation, the Canadian Society for Exercise Physiologists, as well as different community centers like the Black Creek Community Center, the Taibu Community Health Center, Jane Finch Caring Village, etc. And this is growing. We do point-of-care blood sugar testing after we do our assessment of diabetes risk, and then we give an oral glucose challenge to see how blood sugar levels are at baseline, and then again 6 months after our exercise intervention. And we are seeing improvements. The activities are very fun to do, actually. I didn't even know what BollyFit was until I went to the South Asian community and realized that this is a type of dance that they like to do. Why not that be the exercise prescription? It works just fine. African dance, soca size, reggae aerobics, line dancing, Tai Chi, as well as pole walking groups and traditional stationary cycling. We do need more money for this project, but we're putting in another proposal. So I'll leave you with this little cartoon. It wasn't really insulin. You don't have diabetes yet. It's just a warning shot. Physical activity, it's the most powerful medicine. And for best results, use it daily. Thank you.